Good afternoon. I'm Dr. Michael Brand-Sawatsky, Senior Physician Executive here at Hoag. Dr. Allison Brooks was to be here to make the next introduction of our guest speaker today, but she's been delayed. And so because we have a limited amount of time for our guest speaker, I will accede to doing the introduction. Dr. David LeGroux has joined St. Joseph's Hoag Health recently from a different system that shall go nameless. Dr. LeGroux had an academic career before coming to us, and also a practice career. He started out life as a professor in Kentucky, University of Louisville, and then moved on to UC Irvine as a professor of obstetrics and gynecology. He subsequently moved into the private world, or the community hospital world, and was at Saddleback Hospital directing women's health services there, and currently, as of a year ago, about, David? 3 months, boy. Okay, so it seems like a year. He's done so much in his 3 months that it really seems like a year. He's been the St. Joseph's Hoag Health, the regional director, executive medical director, I think is the right title, of women's health services. So with his background in OB/GYN and his academic and as well as leadership background, he will help the region, meaning the combination of the St. Joseph's hospitals, St. Jude's, St. Joseph's Mission, and the Hoag hospitals, as well as a small place in Apple Valley, will help coordinate and standardized women's services and hold us accountable for quality metrics that optimize the care of our female patients. But one of his side interests is the topic he's speaking on today, which is physician burnout. As you know, the triple aim in medicine has been announced by the Institute of Medicine and other policymakers as clinical excellence, service excellence, and cost optimization, as I call it. Yet now there's a fourth aim, so now we're seeing the quadruple aim, and that is caregiver experience. And so physician burnout is part of the quadruple aim now that looks to expand and improve healthcare overall. So David, that's probably too long of an introduction, but insufficient for all your accolades that are listed in your CV, so I apologize for that. So we'll hear about physician burnout. Thank you.
That's great. Thank you. So I walked into work this morning and was greeted by the head of our system with coffee and donuts because it's St. Joseph's Day. So I was reminded that if I give a talk or if I start a meeting, I have to have a reflection. So this is my reflection. Laugh when you can, apologize when you should, let go of what you can't change. Life is too short to be anything but happy. So I think for physician burnout, that's an appropriate reflection. As was said, I have a real interest in this, and I appreciate you guys giving me the opportunity to sort of crystallize my thoughts on physician burnout. I think when you're in an executive role and when you're dealing with medical directorships or any other kind of physician leadership, you realize and get a broad view of what goes on, in a multitude of different settings, and you realize that some of the symptoms we're going to talk about in a little bit of physician burnout are there and really something that you have to deal with on a regular basis. So it is a big part of my living, doing the job I'm doing and trying to work with people. But I think on a more humanistic thing, I think as we go over some of the numbers and what's going on, you realize this is a great tragedy of medicine. Not only this could be nurse burnout, this could be respiratory therapy burnout. This is anybody who deals with the medical care system. That you have to realize this is going on. So just a little background. First of all, what is burnout? Burnout is this situation where your reaction to stress is you just can't deal with it. Your ability to recover from your day-to-day stressful situation, and I would argue that most practice of medicine is a stressful situation day in, day out. But once you reach burnout, you simply can't recover. Your energy is just lost and put out. And one reason in medicine this persists, in other words, we just don't crash, burn, and everything fall down, is because our training doesn't let us. If you think back to your days in medical school or residency or whatever, you were absolutely trained to put up with this kind of abuse and yet keep on going and things of that nature. These thoughts, by the way, if you want more on this topic, I'd really encourage you to buy Dr. Drummond's book on Stop Physician Burnout. It's really a nice text that reviews a lot of this stuff and is a good thing. Now, to put it in modern terms of Survivor and TV, I guess today, especially since we have a president who's comes from the reality TV world, we have to relate to that. So here's things you hear burnout physicians say: I just want to get through the day. How can I finish and get out of here? And if this keeps going, I might hurt someone. And I will tell you personally, I've said a lot of these things in one form or another, maybe perhaps with the Appalachian flair, but the bottom line is, I think a lot of physicians and folks feel this way about their daily life. Now, to measure burnout, there is a tool that's been developed outside of medicine called the Maslow Burnout Inventory, or MBI. And Dr. Maslow took the key symptoms and put them together of emotion, depersonalization, and a downside of personal accomplishment, and put these together into an inventory tool that can be used. So most of the data that I'm going to share with you in studies is based upon using the MBI to assess how folks are doing. If you drill down on Maslow's symptoms, you can get three big buckets. First is exhaustion. Everybody is extremely tired, and as I said earlier, can't recover from that. And things are chronically miserable and or described as on a downhill spiral trajectory. There's this sense of depersonalization. And so what that means is that you're impersonal towards the folks that you serve. They call it compassion fatigue. The doctor will become cynical or perhaps sarcastic when they describe patients or what patients' actions are. I told them to do that, but they just weren't smart enough to follow my instructions. They weren't smart enough to figure out their medications, et cetera. In other words, they begin to talk about patients that if they were outside and looking in, they probably wouldn't act that way. And it really comes against the prime directive of patients come first, right? In fact, you can describe this whole dilemma that we're in as trying to put, going against that directive of putting patients first versus what your own well-being is. And then, of course, this translates into lack of efficiency. Because you doubt the purpose of your work, you tend not to work as well. You're not obviously a team player, and really you get this feeling like your work doesn't really matter. Now, Drummond describes three buckets that you deplete. You obviously, physically, you feel exhausted. Emotionally, you're drained and can't be compassionate. And then spiritual, and he didn't mean that in the religious sense. He meant by what your core beliefs in. You begin to doubt whether you really feel like, you should be compassionate, or you should have things that, when you thought about your decision to go into medicine, you abandoned those sort of core principles. Now, how prevalent is burnout? Pretty consistently, most studies have said about 1 in 3 physicians will document and have some symptoms of physician burnout. My last group meeting, I would have gone with the 60% thing, but okay, I can live with a third. Seriously, I think it's something, if you begin to look around and you kind of begin to see how people react in meetings or in their day-to-day care, things of that nature, you really begin to see that. As we'll talk about, these rates are higher than in the general population. And it's interesting that maybe because, again, in our training, we're taught to just deal with it, right? Whereas in business these days, the success is measured a different way, and they've sort of figured this out. It's really simple: hire the best people and then take care of those people and care about their well-being. And I think in business, most corporations now, I mean, look at Google, look at some of the tech companies, they almost go crazy in trying to make their employees happy and healthy and things of that nature, whereas we tend to just in the medical field say, hey, let's deal with it, and that's how we train. This is a study by Dr. Shannenfeld and the group out of the Mayo Clinic that was published about 5 years ago when they compared burnout rates using that scale I suggested to you. They found that about 38% of physicians have symptoms of burnout versus only 28% of the general population. And if you ask the question about being dissatisfied with their work-life balance, it was about 40% of physicians were dissatisfied versus 23% of the general population. So their conclusion was obviously that physicians are in a poorer state than the general population. Now, this affects all specialties. This is a Medscape, one of the Medscape surveys where they ask about burnout. And this particular one was taken to highlight internal medicine, but you can see virtually every specialty there is represented. Obviously, the busier specialties tended to be at the top, but not necessarily. I'm not sure why psychiatry was on the bottom. I think they're trained to not get tricked into saying they're burnout. I guess that's probably the reason. But, I can understand why the dermatologists aren't burnout, but I can't answer that for psychiatry. And I apologize to the dermatologists in the audience. There are, interestingly, gender differences in burnout. Female pattern burnout is usually primarily demonstrated as a feeling of exhaustion. They also can show cynicism, sarcasm, and compassion fatigue. And they will oftentimes ask the question, what's the use? This, again, depleted spirituality where they just, don't care anymore. Males will primarily present as cynicism, sarcasm, and compassion fatigue. That is, they do have exhaustion. It's very rare when they question what's the use. They don't want to admit they've made a mistake going into medicine and do that. They still get that in their mind as to how they do that. And the other big difference is women will ask for help and men will not. And the way to remember that is it's just like directions, right? We just don't ask for directions. And I'm so proud of that. Anyway, what are the effects? So these things have been demonstrated to be are documented to be shown. There's increase in clinician errors, which I think, given the description of the folks I'm talking about, that makes sense. Reduced empathy for patients. It's hard to be empathetic and cynical and sarcastic at the same time. Obviously, you're not going to get great patient satisfaction scores if you approach people in that fashion. Patients don't believe what you're saying as much, and so you end up with decreased patient adherence to treatment. So if you think about it, that makes a lot of sense. And then, of course, you see an increase in physicians who want to leave practice and just get out altogether. Again, pretty obvious things, right? Again, there are other things here. This is an expanded list, but this list actually has some of the serious effects of divorce and suicide, and I'm going to talk, and drug and alcohol usage, and I will talk about that in a bit more detail in a couple of slides. But you know, you add on to that list, you begin to see things acting out and become it's not just that they're not performing well as physicians, they begin to harm themselves. Surgeons, this study again by Shanafelt and the workers at the Mayo Clinic found that about 1 in 16 physicians reported suicidal ideations within the prior year. And very few of those, of course, sought help for those. And of course, it explains some of the suicidal rates in physicians and things of that nature. And again, you know, it's for, especially for a specialty such as general surgery, that's a real problem when 1 in 16 of your providers is so down that they're thinking about suicide. But it's not just a specialist. This memo study that was put together by ARC and things found that primary care doctors are the same way. They're burnout, perhaps not because people are dying in their face or things of that nature, but it's the stress associated with their organizational aspects of their jobs and the lack of control and some of the things we're going to talk about in a few minutes. So depending on your specialty, there's perhaps different stressors there that are causing it, but the end result is the same. Now, in addition to hurting themselves, this obviously impacts the family. We mentioned how it impacts the patients earlier, the staffs, the colleagues, the people they have to work with. And the way to think of it is this hurts the healthcare organization, or in that fact, all of the country by having this type of situation going on. Now, there actually have been studies looking at the effect to the family. Men, a bit less than women, will admit that they are, compared to the other working population, by about a 3 to 4-fold increase, that they don't have as good a relationships with their children as they should, simply because of their job. So again, I think if we went into pre-meds and gave this talk and said, by the way, there's a 4 times the chance risk that you will not like your children if you choose to go in our profession, that would probably not be a great sales pitch, right? But it's something we obviously live with on a daily basis. Now, why are these things coming about? And I will tell you in a minute, because a spoiler alert, I am going to mention the EMR. For those of you, fortunately, we didn't get to that part of my CV about me being a clinical informaticist and making a lot of people adopt EMR. But again, one reason I got interested in this topic is because it's at least one of the newer reasons that cause this problem. So what are the big 4? Well, it's lack of control, it's time pressure, it's chaotic workplaces, and it's a lack of alignment of the values as you see them as a practicing physician versus what the organization supposedly sees. And I would argue if you went in to any doctor's dining room on any given day, you could hear a few of these come up, right? People complaining about their work conditions. Gosh, things are too busy. They overscheduled me in the office. My clinic is a crazy place. The OR, everybody's running crazy because they added on yada, yada, yada. When you get into it, this describes the world of modern medicine. Now, Drummond actually likes to remind us, though, that that's not all that's going on. Obviously, there is the practice of medicine, and that's what I was just talking about. But it can be your specific job, and that gets into some of the conversation about the primary care doctors, because again, were you overscheduled? Does your EMR not meet your needs? Do you not have adequate support staff, et cetera? In other words, there's a lot of factors within the specific job that need to be addressed. Your life may be an issue. If you're not having a good relationship with your spouse, or perhaps you can't find a spouse, or perhaps your kids are giving you problems, or someone, mom or dad, or your spouse or child has a serious illness, that is a stress. And then, of course, the condition of how we are conditioned from medical school to try to deal with this. Again, we tough it out. That's what we were taught to do, and I think most of us do a pretty good job of that, but that's not necessarily a healthy way to respond things in balances. So when we look at the various sources of stress, it's all of that contributing to burnout, some of which we can control, some of which we can't control. And so in a little bit, when we talk about how to deal with this dilemma, we will address these things. By the way, there's also data in the literature, and I popped this graph up. It's hours spent seeing patients each week versus the chances that you're going to be exhausted or depersonalized. Obviously, it's a linear correlation. The more hours per work hours per week you work, the more likely these things are to happen. Again, no great surprise, but it has been documented. Now, the other thing that's been observed is that things are getting worse. Seems like that things are getting worse. Well, why is that? Well, you probably can just turn on the evening news and get a good idea of what's going on. Healthcare reform and things of that nature, those guys in Washington are not exactly smoothing our world, right? And I don't think anybody would argue that. We are seeing more volume. You know, we're chunking out more widgets per hour than we ever did before. As reimbursement's gone down, one of the key strategies is you do more stuff. So the less you get paid per widget, the more widgets you're going to make so you can keep your income the same. EHRs were first and foremost designed to improve billing. They were not designed to improve clinical work, and I will be happy to have a 3-hour discussion with you about that fact, but they are getting around to figuring that out, but it's not been simple. You spend more time documenting, because the other great achievement that came out of Washington was E&M coding, right? You got to do this, 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 and this, or we're not paying you. Right? I mean, what a terrific way. And by the way, if you don't write it down, you didn't do it, and therefore I'm not paying you for it. So that's there. I think patient expectations are higher. I think in the new world, especially with social media, for those of you still practicing, if you want to have a really depressing afternoon, go back home and figure out your Yelp scores. Some of them are good, some of them are kind of ugly. You only need 1 or 2 bad patients to spread the word. And that ties into the negative views of doctors. At one time, yes, we were put on pedestals that we didn't deserve. But on the other hand, I would argue a lot of people do deserve to be put on pedestals, and we don't get the credit for saving people's lives and improving those lives quite the way we do, we get to focus on these guys make a lot of money and drive Mercedes and live in nicer homes than I do. That's the perception. And then, of course, the duty hours where we've made, we'll lock in how many hours a week you can work, whether it's you work for a clinic or you're a resident or whatever, but we still want you to do the same amount of work, so it becomes more chaotic, right? The other point to be made is that while we are going through, and you're seeing consolidation where people are going from small private practices into large group practices, guess what? Burnout is just the same. The stresses may be different, as we'll talk about. If you're in private practice, you worry a lot more about overhead and little details of staff. On the flip side, when you go into large group practices, you have less control over what's going on, and that becomes a stress. So again, practice models can address it, and there are certain things you can do, but they don't solve it. Because again, look at these: time demands, lack of control, lack of autonomy, workload intensity, financial strain, unmet personal needs. These are all things that can happen in any kind of practice, in any kind of different specialty, et cetera. These are all things that we can't do that much about. And again, to sort of back up these individual things, this is the Medscape report looking at when they ask people what's leading to your burnout, what's leading to your stress, things like bureaucratic tasks, working too many hours, increased computerization, feeling like just a cog in the wheel, income not high enough. Again, I would challenge you to go in the doctor's dining room and listen to conversations. This is what a lot of people talk about a lot of the time. Another important thing, and this again comes from the folks at the Mayo Clinic, is that they found that it is critically important that physicians should be given at least the number. When the number falls below 10 to 20% of your time that you're not doing something that you're really passionate about, you see burnout just skyrocket. So it's very important when we design what we do for a living and how we practice to make sure that we don't throw out the part that we love about practice. So I'll use the surgeon. If you took the surgeon and don't let them go to the operating room and you make them do, wound clinic or something like that, it's likely that you will increase their stress and their burnout. So it's very important that we as administrative doctors or other people looking at what we're asking people to do, keep this idea of career fit, in other words, matched to their passion in their job. Now, here's the thing. I know if I ran a survey, everybody would jump me on this one, right? And this was published about 3 years ago, but there's other studies to show it, that if you looked at people using the EMR, that it clearly increased their emotional stress compared to not using it. Now, obviously, what we as clinical informaticists have tried to make the excuse, well, that's not the one we designed, that's somebody else's, you can make all these, but there's no question that if you have an EMR and every time you make a click, you got to wait 15 to 30 seconds before the screen changes, people go nuts. Now, the good news is, as I said, the major EMR companies, and especially, as you know, we're getting Epic here. Epic, literally, the lady went out and hired 400 designers to help her make the screens look prettier and the click times and do all the things that we as users, it will improve our experience. And I would argue that's a critically important thing for the success of electronic records down the way. Again, just another paper. I won't, knock this home, but it clearly comes up in pretty much all the modern surveys of burnout that the electronic record needs to be looked at. Now, again, I will defend it a little bit and say, but we are getting reimbursed better. We can get quality data back, and there's some good sides clearly to the EMR. But I totally agree that this is a critical element to the long-term success and adoption. So let's talk about, as depressing as all that sounds, what can we do? Well, first of all, this is a dilemma, not a problem. And I'm stealing this from Drummond's description. Here's the difference between the two. A problem is something you identify it, you treat it, and it improves and gets better, right? A dilemma is something you essentially have a choice between two bad things here. I can keep working as a physician or, and take care of my patient, or I can go home and rest and take it easy. So that's a dilemma, right? Because if I go home and take it easy, the patient doesn't do well. Well, that violates my belief that the patient comes first, and this is why I went into medicine. So the other way to think of this is that burnout is a chronic disease, like hypertension or diabetes, that you can't cure, you have to manage or treat, versus strep pneumoniae, where we may be able to give antibiotics and clear up the disorder, right? So again, what we're dealing with is a dilemma, and we have to think of it that way because our strategies have to be ongoing. So for the individual physician, what are their choices? Well, you can recognize it, change whatever you're doing, how you're doing it, and your relationship with your career and recover. And that's what we're going to talk about. That's a good idea. Number one is what you want to do. What's the other ones? Well, it can become a chronic condition and you just put up with it, and then you begin to see disruptive behavior. You become sarcastic. You begin not being compassionate towards your patients. You make it on the list of the people, at the department meetings no one wants to listen to, that sort of thing. It can also play out, like in number 3 there, that you develop something bad, like alcohol, substance abuse, divorce, depression, or obviously suicide. We talked about that one. And, or you can just quit making a living as a physician and go back and change careers. And obviously, there are people who do that. There are people who find something else they can do, but the number of options for the vast majority of physicians are pretty small. So what are some of the personal changes that can be made? Well, the first thing that Drummond recommends is that you take time to decide what you want to do. Think it through. Recognize that this is going on, that you're having to do with it, and then you begin to take these small baby steps in that direction as to what's to do. He also recommends that we remember why we went into medicine, right? You went in to help. You thought it was a pretty noble profession. You thought it was a good thing to do. Get off the tracks that people have led you onto. This is where it gets, a lot of people, we get in these grooves that others have told us this is the way we need to do it, because it either worked for them or they think it's the right thing, whatever. You need to determine your own track in this. This is something you really need to do it. And this put your burnout to its highest use means that you really use this to motivate the change. In other words, recognize, hey, I'm burnt out, or my colleagues burnt out. We got to do something about this. Now, again, there are personal changes, there are system changes. We'll talk about this. Dr. Linzer, in a speech to the American College of Physicians, listed this: promote engagement, how well the docs are tied together to that, lower the bureaucratic work, and I would put improve the EMR in there today, reduce the number of patients. Maybe we're just burning these guys out because we give them too much patient or inadequately staffing the clinic or the ED or wherever, and then help coach them. This is not something we got trained in medical school to help ourselves with. So build some organization or some group that's going to help us do this. And so how do we do some of these things? Well, a lot of it's workflow redesign. It turns out when you're dealing with the electronic record, it's a lot of times that's already been solved and someone else had the same problem, but you don't know about the fix or how to change your workflow. And so you keep doing it the hard way, right? And I can't tell you how many at the elbow sessions I've had with doctors where I walk over and say, you know, if you click over here, it gets you to the right thing, right? And boom, bada boom, you're done, right? But unfortunately, they didn't know to click right there, which again is on us, not on the user, but I'm just saying. Better communication, talking to each other, taking a little time during the day. Dr. Quilligan, one of my mentors, used to say, work at a job that you can have, that you have a group to go to lunch with and can talk. And I think that's sage advice for anybody. And then, as a system, we need to develop quality improvement projects where we're really working, as was said, this is now part of the quadruple aim, or actually the original triple aim when they said experience meant experience for the patient and experience for the providers. But we need to consciously work on that. So what are some of the ideas that Linzer threw out? Well, again, less time pressure. Give them more control. It's a big thing in Toyota production or lean that you go to the workers and let them help you, design a better system. Extend appointment times. Again, don't let the CFO decide how long an appointment time should be. That's a clinical decision, not a financial one. Offload the non-clinical work. I think in the ambulatory world, you see more and more well-run offices where the menial tasks, the things that a doctor doesn't need to do, let them do it. Give them catch-up time. Build into the schedule, hey, you're never going to get all your notes done right away, so I'm going to give you a couple hours to work that in. We don't like to work in chaos. Have a well-oiled machine. Have people working. Space considerations. There's some new work being done on 7 on, 7 off. Work 7 days in a row and be off 7 days. Why don't we do that? Well, we never did that. But again, that's a way to look at it. Obviously, as an organization, you have to support the work-home balance. And again, I think, especially today with the changing millennials and others, we have to figure out how are we going to have part-time partners? How are we going to have practice styles that let people be parents to their young children? It just matters more. And then there's clinician wellness. We really need to keep people healthy and happy, right? And again, this is something that we were not taught in medical school. We were taught 180 degrees the other way. But again, we should have an action item, and just as you see many corporations doing, and I would argue most of our hospitals within the health system do this for their employees, really have a focus on keeping people well. And then there's other sort of what I'll call interesting things, candy rounds. I don't know. I would have a hard time pushing something that raises diabetes, but nonetheless. All kidding aside, come up with creative ideas. A lot of people have done this in various clinics, in situations, and they can be very helpful ideas. This is one idea for surgeons. I think particularly to my surgical colleagues, again, I think it's great that you're serious and focused and not as lighthearted as we are in OB, but Nonetheless, same way, you need to really figure out within your life how to balance that intensity that it takes when you're operating or when you're in, working and taking out a brain tumor. You need to figure out just as important how to look for combating stress and finding ways to relax and go out. Individual strategies include a number of things. There is resiliency training. People can be trained to deal with things more. Obviously, stress reduction and self-care, teaching them how to take care, exercise, hobbies, and then actually, even though we tend to make fun of people, perhaps we certainly do in Kentucky, about yoga and reflection and mindfulness, there's actually literature, strong literature to support that that's a great idea. So, for example, here's a wellness program that focused on mindfulness and teaching people to breathe and reflect and things of that nature. And they actually showed by doing the MBI before and after that they could improve and reduce depersonalization, and it lasted for over 12 months after the study. So again, these things that we've, probably wouldn't have ever brought up when we were medical students, these can be good things. The other thing is, and I love this comment by Drummond, was to deprogram our training. Right? This was all hammered into you day after day, night after night, but it's okay. In fact, it's absolutely necessary to take care of your own personal needs, right? So that means sleep, nutrition, exercise, and time with the people you love. That's okay. He gives the example of keep on your calendar your work stuff and your personal stuff, right? Don't have two calendars. And I think, that scares people. What do you mean? They might see that I'm going to the movies Friday night, or I've got date night, or gonna go watch a kid's soccer game. If you had brought that up 10, 20 years ago to your attendings, quote unquote, what would they have said? They'd have gone crazy. But it's okay. It's also okay to admit you're struggling. Wait, give me a break. I'm behind. You got to yell out for help. It's okay to give stuff to my team. I don't have to do it all. I think through my career, I've seen so many of my colleagues, and I'm as guilty as they are. I can do it a little bit better, and so I'm going to do it. But it's okay to let go and let other folks do it. There are many places in life where good is good enough. Not everything has to be perfect. And again, when you get into certain personalities, the bottom line is we're perfectionists to one degree or another, I think. And it's okay to say, I don't really have to spend, I don't need a 5-page note when a 2-page note would do, right? I think that's it. The patient doesn't always come first. If we do that every single time, then we're going to trash ourselves. It doesn't mean that we don't have them taken care of. I'm just saying you have to balance that out. I don't need to have all the answers. This is one, when I read it, I said, well, gosh, I'm fortunate because I have all the answers. But I see where other people might not have to have all the answers, right? It's impossible to be emotionally free, no matter the hardest person, the hardest neurosurgeon or trauma surgeon or whoever you want to see. The bottom line is they may look like they're not emotional. They may act like they're not emotional. Those emotions are there. Those stress hormones are still pumping out to those people. He actually describes physicians in these categories, which I thought were interesting. You're either a workaholic, a superhero, you're emotion-free, you're the Lone Ranger, you're the perfectionist. These are the things we used to value. We used to mark, I can remember, grading the fellows and the residents by these things, And boy, the higher scores you got on these, the better doctor you were, right? I mean, that's the way we were. Again, we have to deprogram out of this stuff. He also says, take out the head trash. And I love this comment is, and we talked about burnout's a problem, not a dilemma. Do the 180, look at yourself in the mirror, so to speak. Release the superhero, meaning you don't have to do everything. Think of the guy who does a lot of stuff just by getting one plate going, then walking in. I don't know if y'all remember the old Ed Sullivan show, but there used to be this guy on there, and he could get like, what was it, 15 plates going at once? And you looked at it and you said, how in the world? Because he was keeping the plates going. He wasn't starting off 15 at once. He got one going, then he got to the next. Oh, that needs a little spin. And that's how we need to run our life. And we do need to celebrate our wins more. We need to give positive feedback to ourselves and to the folks that we're around. And then he also describes the typical physician traps we get into, right? So, we get in the trap that we got to find the solution out of this, and that's a bad trap. That's right. In other words, we don't have all the answers. The other one is blame the victim, play the victim, right? We love to be, it's just, no one could do this. This just, I got dealt a really bad. We got to get out of the victim mode. When you're in the victim mode, you can't, what you're saying is, it's a hopeless situation and I can't solve this. You really have to realize that everything's solvable, you just have to do it. And then the other thing, of course, the other opposite of that would be just praying for the magic pill. Now, what he does is put these into this matrix where he breaks it down. And I'm not going to go into too much detail with this because I think a lot of the key concepts we talked about. But see, if you break down what are the personal things, what do I got to do in both decreasing my stress and or increasing the things that recharge me emotionally. And same way, what are things organizations can do to decrease the stress versus help recharge the people that work for them. So it's really good. So for example, how do you decrease stress? Well, a good example, check your attitude. Complaining and blaming, don't be the victim, don't be a hater. And he actually goes on, I'll give you an example. Here's one way to reduce the stress, mindfulness. Again, we talked about the study that actually showed this work. Learn how to take deep breathing and thinking through and this state of mindfulness and use it to your advantage. Really, the best description of mindfulness is I am going to get in a state that I'm just very conscious about what's happening now, not what am I planning could happen or worrying about the things that happened in the past. What's going on right now? And that's why the breathing techniques and the other things work. Incorporate personal events. This is to recharge. Again, I mentioned this earlier about put your personal events in your calendar. And you don't bump them for a meeting. You don't bump them for, hey, clinic's coming up. No, you can't add that person on because I've got to be home to go to the show tonight, etc. You prevent those things from going on. And of course, the other one, and I have to admit, is I'm the worst at saying no to things. People come up to me, hey, Dave, will you do that? I'm in. I the number of times in my life I've said no is probably you could count them on one hand. But that's bad. Don't be like that. Learn to say no. Now, organizations similarly can reduce the stress, and we already talked about a number of them, about redoing scheduling of clinics, trying to get people ancillary help, doing things of that nature. They also describe, Drummond does, a burnout work group, not a committee. Committees meet in meetings. A work group is a group that works when they need to get together and things of that nature. It's I think it's a perfect thing. Probably most medical staff should have one of these, where really their job is a group of individuals who help people cope with this, who survey what's going on to see how they're doing, et cetera. Certainly in clinics, in big organizations, this is something that's, like you say, worth the time and effort. I think, I know in the non-physician world, it's about, to get a new employee in is about $250,000 a person. So I imagine physicians are much higher than that when you replace them. So it's worth the time and the money for organizations to do that. And then recharge, putting in exercise facilities or yoga classes, or saying, hey, it's okay to have a work-life balance, and things of that nature. They also mentioned things like get involved in charity events and things of that nature. Again, it gets back to that concept of reminding us of why we went into this. There's a really nice article, I don't think I referenced it in here, by a pediatric intensivist who talks about how, he realized, gosh, he's burnt out and whatever, but you know what? He chose to do this, and he sort of embraces that sadness that he has to deal with of children being very sick and not being able to save them all. That's okay. I'm the compassionate guy that can do that, and that's why he went in. And again, I think more programs that help us realize that are important. What to choose? Again, this is why you get a group of people. This is the great quote by Ken Blanchard, none of us is smart as all of us, right? So I think everybody has ideas. I think a lot of that's thrown out will work in some settings, not in ever. But again, it gets back to that idea of having a work group beyond that. So again, I'll go back to some points of, we had 7 to 17 years where we were taught the doctor gives the orders and the team just obeys or complies. That's what we were taught. We did that for years and years. The chief resident was in charge of the resident who was in charge of the intern, type of things. Again, we are changing into a world where we are going into teams. And it is very important for, regardless of what your practice of medicine is or whatever, we need to be team players and let the team deal with this. Now, some can look at it as I'm losing control, but I would argue for a lot of people what you're really doing is you're shifting a lot of the stress and a lot of the I got to do this myself onto the team as a whole and getting it away. And so again, I think how good we become and as team captains is going to be important. The other tip that Drummond had was managing your boss. And what he meant by that, what he means by that is that you learn to understand your boss. Because again, I think as we get into bigger clinics or you're in bigger departments or whatever, we tend to have more bosses these days than we did when we were all in solo practice and things of that nature. So it's very important that you kind of study your boss, what drives them one way or the other, and learns to do with that. That really helps your own stress and understanding because you know how to interact with them. And again, this from the Mayo Clinic where, they've actually put together a organized leadership plan to deal with this. They have 9 organizational strategies that deal with physician engagement and how they operationalize this. I'm a huge fan of the Mayo Clinic. I don't know how many of you guys have been there or interacted with them or had the things, but this is a group that for years and years, just as they've led in clinical medicine, has really thoughtfully looked out of how they practice and how they take care of it. So again, peoples are doing that. Another thing, again, I mentioned this earlier about celebrating. It might be just as simple as learning how to say thank you a lot of times. thank you for helping me with my clinic today and doing things. And again, these are things that are pretty simple and straightforward, but I would suggest to you build your ability to be compassionate. Just as a source of reference, you may also want to go to the AMA website. They have this Steps Forward program that was put together by Robert Waugh a couple years ago when he was the president of the AMA. He made this his signature focus, and he had this quote of, "The most important patient we have may be to take care of the one that we're seeing in the mirror." It's got some great examples of simple things to do and things of that nature. And again, I would recommend it to you as a good resource. It also has this idea and suggestion that you need to track your progress and see how you're doing. Again, I would make this into a quality improvement project type of thing where you're really mindful of what's going on. So physician burnout is increasing. It's already pervasive and high. It affects everybody in the healthcare system and anybody who knows somebody who's in the healthcare system. I think we need to make our solutions both individually and as an organization. And again, I think these are the type of things we need to look at as a dilemma. Choices, hard choices that we're going to have to make, and as I mentioned earlier, as a chronic disease. So I'd be happy to entertain any questions, or if someone has comments or things of that nature, I'd be happy to address. Yes, sir.
Has a similar study been done on a different type of medical system, for example, the one in the UK?
I think the correct answer is I can't quote you a study. My suspicion is, just as we saw in where they've studied different, whether you're in solo practice or whether you're in a big organization, that you still see burnout in significant degrees. But yeah, I to be honest with you, I don't know is the correct answer. I will give you I'll bet you there's a lot of burnout British physicians, perhaps for different reasons, because they're, faced with not having control and things of that nature. But I think the way to think of it is, I think as we're redesigning our healthcare system, we really have to be mindful of this and the health of the providers that are within the system. Other questions or comments? Cool. Okay, well, thank you very much.